Dr. Joshua Marcus is the only physician in Fairfield County and only one of a few in the state of Connecticut with advanced training and dual expertise in both surgical and minimally invasive treatment of cerebrovascular or brain conditions, including stroke.
We're so pleased to have Dr. Marcus join us on Health Talk today to discuss the latest minimally invasive treatments for stroke patients.
So stay tuned, we're up next. Hello, I'm Dr. Eric Mazur.
And I'm Dr. Andrea Peterson. Today we're joined by Dr. Joshua Marcus. He's a neurosurgeon with the Western Connecticut Health Network. Last year, Dr. Marcus and his endovascular team performed the first endovascular stroke procedure of its kind in Fairfield County.
So congratulations, Joshua.
Welcome.
Great to have you back on the show, and great to have you here in Fairfield County, because I think your expertise is really making a difference to people.
Thanks. I appreciate it. Thanks for having me back.
So I think it'd be really helpful to explain to our viewers what you do that's different and how that helps really improve the prognosis for people with stroke.
Sure. So I think it's important maybe to go back and talk about what the treatment for stroke has been. And so the recognition of stroke symptoms in the community by family members or friends is probably the most important treatment of sorts, because it gets people to the hospital, to the right hospital that can treat stroke. And for the longest time, that treatment was a clot-disrupting medication.
I actually remember the days where their treatment was to watch the patient and watch them, the stroke evolve. So, but keep going.
Sure.
I think then we introduced the clot-busting agents.
Right, and it was really the cardiologist who developed this medication in the 80s, and then the stroke doctors who extrapolated that in the 90s to try and break up this clot with a very potent intravenous medication called TPA. And ultimately, that was our treatment for many years. It has some efficacy for certain patients, but not for all patients, and not for patients with a large occlusion. And so the treatment.
So what we're saying is that a stroke is due to a blood clot that forms, and often, most of the time, due to a blood clot that either spreads to the brain, embolizes the brain, or forms in a blood vessel of the brain, cutting off blood supply. And we want to open that up as quickly as possible, because brain tissue dies within minutes.
Exactly.
So this clot-busting medicine that was given in a vein sometimes dissolved that clot and allowed blood to get to the brain. Sometimes it worked, sometimes it didn't work, and it did have some potentially serious adverse or bad effects
and
too.
Often incompletely work. So you got some improvement, but not the dramatic improvement you would hope for.
Exactly. And again, compared to watch and cross your fingers, that's pretty good. As up to 35% of patients can be made better, markedly better with this medication, but that still leaves a huge subset of people who are left severely impaired or even worse despite the medication. And there's a lot of people who can't get the medication. If you take blood thinners or Coumadin, or you've had surgery recently, or you haven't gotten to the hospital fast enough, you are not eligible, because it puts you at risk for those complications you mentioned, such as brain bleeding, which can be fatal, obviously. And as a result, we have developed over time a procedure to go through the blood vessels themselves, through the groin, up through the aorta, and into the brain directly to remove that blood clot. A procedure called a mechanical thrombectomy.
That's an amazing sort of trip when you think of how far you go with that catheter. Maybe you could say just a few words about how do you do something like that? Because you're really threading it up through a mass of vessels to a very small area in the brain.
And all really important blood vessels, too.
That's right. You need each one of those vessels.
Right.
Sure. And you're using catheters that are less than an inch or two big, actually. So we use X-ray guidance, very similar to what an interventional cardiologist may do in the heart, to use X-ray to guide those catheters. They're sort of a series of catheters. One builds on top of the other, and a wire to guide things all the way up. And so the X-ray and some manipulation at the groin allows us to get all the way up into the brain.
And then what do you do with the catheter that actually allows you to grab or get rid of that clot?
So a couple of options. One is we use a large catheter to go right up to that clot and attach a big vacuum, a big aspiration or suction device to the tube that's coming out of the groin, in the hopes that you can suck the clot right out. Another option is to place a stent, not a stent that stays there forever, but a sort of metal tube that traps the clot. And then that trapped clot comes back with the stent itself, called a stent retriever, or an aspiration thrombectomy.
Do you ever give the blood thinners or the clot busters right up into the vessel, or is that not something that's typically done?
It's not something that's typically done. There's a good data from 2013 in the New England Journal of Medicine that shows that that is just not effective. That was the first natural progression. You have the blood thinner in the vein, let's give it in the artery, but we didn't find that giving it in the artery was any better than giving it in the vein. And in fact, the data that supports what we're doing now was published in several international trials in the New England Journal in 2015. So it's a fairly new, widely accepted treatment for stroke.
And Joshua, how quickly or how much time do you have between the onset of symptoms and the time to remove that clot?
The data will tell us that there are a large percentage of patients who are made better if we get to them within 6 hours, which is a little different than TPA, which currently has a 4.5-hour window. But new data is showing us that there is actually a subset of patients between 6 and 24 hours who can be made better with this surgery if they have sort of the right dynamics of their brain blood vessels.
Which is potentially fantastic news.
Absolutely. And this is not all stroke patients. These are patients who have big vessel occlusions. Mm-hmm. And big vessel occlusion, if left untreated, leads to big stroke. And so these are patients that we think we can make dramatically better with this intervention.
Why do you think the window for intervention is so much longer with the direct intervention?
The concern with the TPA is that if the brain, like we had mentioned before, dies immediately, once it starts losing blood vessels are dying by the second and by the minute. And if you deliver this clot-disrupting medication to blood vessels to brain cells that are already died, they're very friable and they can hemorrhage. And so we're very conservative about not treating patients who have a stroke or territory that is dead that could bleed. And so we think that this intervention carries a lower risk of causing bleeding in the brain, and therefore we can expand the window, accepting that there are some brain cells that we may not get back, but a lot that we still can.
My understanding is another risk factor for bleeding with the clot-busting drugs is a very large stroke, because presumably you have more dead brain there to bleed into. But are you able to handle larger blood vessels and larger strokes with the direct method?
Absolutely. In fact, larger blood vessels and larger strokes are what it is currently approved for. We haven't quite gotten to the technology where we can take a catheter all the way out to a tiny, tiny blood vessel, a millimeter or two big in the very outside of the brain. But then again, if that blood vessel is blocked, not as much brain is without blood and oxygen, and therefore not as much brain will die and not as much neurologic impairment as a result.
How successful has this new technique been for helping treat stroke patients?
It's been dramatically successful. It's been a game changer in the face of stroke. You're taking patients who are coming to the hospital with an inability to speak and an inability to use one side of their body, and you're sending them home back to their normal life.
So do you see, like with the cardiac removal of clots, you see a dramatic improvement of the heart right away? Do you see the same kind of thing neurologically?
Absolutely. We're doing this procedure under anesthesia, but after patients are waking up under anesthesia, we're seeing a good percentage of patients talking and moving just right on the operating room table.
Wow.
The context of this too, for people not at home, the clot-busting drugs, it was really mostly a late effect that you saw, less late disability. When the studies were done, you didn't often see some of this dramatic improvement right after the procedure.
Right, absolutely. And the studies, again, are still 90-day improvements. I mean, we have data that shows that up to 3/4 of people can be restored to functional independence at 90 days. But we're seeing a good number of patients now, as the technology gets better and the systems get better, that are much better even during their hospital stay.
I think that bears repeating a little bit, because so in the past, so many stroke patients, if they had a big stroke, as you said, it impaired their speech, impaired their ability to swallow, left them unable to move half their body, their quality of life was severely affected. And now you're saying some of those patients can go home and live normal lives. And
absolutely.
Amazing.
It has certainly changed the narrative of stroke. You took a disease that was devastating, it looked devastating. A lot of patients died as a result, and now you're restoring function to these people. And again, certainly in a large percentage of the older population, but we had just a young patient that we treated this week, and so it affects all ages.
And it's really important that you get to those patients early. So perhaps you could go over again some of the symptoms of stroke and how important it is to get that patient to the hospital immediately if they have those symptoms?
Sure, absolutely. The key symptoms we think about are trouble with your face. If someone's smile is asymmetric, or they have a facial droop, or one arm or leg doesn't work as well as the other arm or leg, or difficulty with speech. So difficulty expressing speech, making language or producing language, or language that just doesn't make any sense.
So people shouldn't wait to see whether this goes away.
Absolutely not. The faster you get to the hospital, to the right hospital, the better off you are in the long run, either for the clot busting medication or for a surgical procedure.
And tell us about the right way to get to the hospital, because I believe in our community and other communities, some stroke care actually begins with paramedics who arrive at the home.
Sure, and these are symptoms to call 911 immediately for. They are as emergent as anything, as chest pain, or as someone who is impaired or can't breathe. I treat them the exact same way. This is a trauma situation of your brain.
And many times, because time is so important, paramedics, if they recognize that what the patient is having is a stroke, can call ahead to the emergency room, notify the emergency room
get the
physicians.
neurologist there, get yourself there.
Who activates
Absolutely.
a whole stroke team,
Yep.
who then can be ready for the patient in as short a time as possible to take care of them.
Right, and that's what specialty stroke centers are good at doing. They have a sophisticated means of pre-notification, making sure by the time you get to the hospital, you have already gone right for your CAT scan, you've gotten your IV placed appropriately, and you are ready for any possible interventions, rather than if we were to go to the emergency room, waiting room, and sit around for a period of
And
time.
do not go to a walk-in or.
Absolutely
Right.
not. Yeah.
And this is not a time to go to your primary care physician.
No, most primary care physicians, if you call their office, they will instruct you to go to the emergency
Appropriately
room.
so.
Yeah, absolutely. We should point out this treatment does not apply to all strokes. Just say a couple of words about that.
Sure. So TPA is sort of still our mainstay of treatment for all comers with stroke. This treatment, mechanical thrombectomy, applies to a percentage of patients who have a large vessel that is occluded. So the vessels that are in your neck, or the vessels that come up and first go into your brain before they branch into a lot of smaller and smaller vessels, because an upstream occlusion prevents all of those other blood vessels from getting blood supply. We are getting better. We are getting further out into the brain vessels, but for now, these are patients who have severe symptoms: inability to move, inability to speak.
This is an amazing change.
And so exciting.
It really is.
Sure, yeah. I think it will only get better as we find the patients that we think can benefit, and as we get patients to the right
It's
places.
very, very exciting,
Thank
Joshua.
you so much for being on our
Sure.
show to share all that important information with our viewers. Thank
Sure.
you. Unfortunately, we've run out of time. We really want to thank Dr. Joshua Marcus for being our guest today on Health Talk.
And please send us your questions and comments about Health Talk to healthtalk@wchn.org. Andrew and I would love to hear from you.
Thanks so much for watching.
Until next time,
Be well.